Today, we're diving into a really fundamental concept in pharmacology, nonlinear pharmacokinetics. We're going to break down what happens when the body's systems just can't keep up with a drug, and why understanding this is absolutely critical for keeping patients safe. Let's jump in.
For most drugs, the math is pretty simple. Double the dose, you double the concentration in the body. That's what we call linear kinetics. It's predictable, it's a straight line. But for some drugs, the story is totally different. Doubling the dose can cause the concentration to just skyrocket. That's nonlinear kinetics, and that steep, dangerous-looking curve is exactly what we're here to understand.
Okay, so let's put an official definition on it. Nonlinear pharmacokinetics, sometimes called dose-dependent pharmacokinetics, is what happens when that relationship between the dose you give and the concentration you get is just, it's not proportional. The usual predictable rules of pharmacology start to break down.
So here's our game plan for this explainer. First, we'll compare the nice, predictable linear world with the tricky nonlinear one. Then we'll dig into the root cause of all this, something called the saturation principle. We'll see how this messes with a drug's entire journey in the body, look at the math that actually describes it, and then, most importantly, we'll connect it all back to why it matters in the real world.
First up, let's start in that ideal, predictable world of linear kinetics. This whole world operates on a rule called the principle of superposition. And all that really means is that every dose of a drug acts on its own, which makes everything super easy to predict.
So, in a linear system, the body's processes, like how fast it clears a drug, stay constant no matter what the dose is. Because of that superposition principle, you can figure out the total drug concentration just by adding up the effects of each dose. It's simple. But in a nonlinear system, that principle completely fails. Key things, especially drug clearance, actually change as the dose goes up. And that's why doubling the dose can lead to a much bigger jump in concentration.
So, what's the culprit here? What actually causes this breakdown in predictability? Well, it all comes down to one single core concept, the saturation principle. I want you to think of it like a highway during rush hour. Your body has these specialized enzymes and transporters that process drugs. At low doses, it's like the middle of the night. Plenty of open lanes, traffic is flowing smoothly. But as you increase the drug dose, you're adding more and more cars onto that highway. And eventually, you get a traffic jam. The system gets totally overwhelmed or saturated, and it simply cannot process that drug any faster. And this traffic jam, this saturation, it doesn't just happen in one place. Nope, it can happen at any stage of a drug's journey through the body, a process we call AIDME. That stands for absorption, distribution, metabolism, and excretion. This slide here gives us an amazing map of that entire journey. Now, don't worry about catching every single detail right now. Just think of this as our roadmap. What it shows is that at every single stage, from absorption in the gut to distribution in the blood, metabolism in the liver, and finally excretion by the kidneys, there are potential bottlenecks where our body systems can just hit their absolute limit. So let's break each of these down. Okay, so let's follow the drug. During absorption, the carrier proteins in our gut can get maxed out, which is something we see with a drug like gabapentin. Then for distribution, the proteins in our blood that carry drugs around only have so many parking spots. When they all fill up, like with phenytoin, the amount of free, active drug floating around goes way up. Metabolism is actually the most common place for saturation. The liver enzymes that break down drugs like phenytoin and even alcohol just can't work any faster. And finally, during excretion, the transporters in the kidneys that are supposed to kick drugs out, like penicillin, can also hit their limit. And this table just perfectly pulls that whole chain of events together. You can see exactly how a specific mechanism, like an enzyme getting saturated during metabolism, leads directly to an effect, in this case, a higher plasma concentration. Or check out how when those protein binding sites get saturated, the amount of free drug goes up. It's this direct cause and effect that's really at the heart of what makes nonlinear kinetics tick.
Okay, so we've got the concept, but how do we actually describe all this behavior with math? Well, for that, we turn to something called the Michaelis-Menten model. It's the classic equation for these kinds of capacity-limited systems.
Now, this equation describes the rate of drug elimination, but don't get hung up on trying to solve it right now. Just focus on two key parts. Vmax, that's the maximum possible speed of elimination. It's the system's top gear. And Km, the Michaelis constant, is the drug concentration you need to get the elimination rate to exactly half of that top speed.
Let's picture it like this. The blue shapes are your enzymes, and the red dots are the drug molecules. When you have a low concentration, there are plenty of free enzymes ready to work. But as the drug concentration goes up, more and more enzymes get occupied, until, finally, every single one is working as fast as it possibly can. At that point, adding more drug won't make things go any faster. We have officially reached Vmax.
This graph shows that transition perfectly. See, at low drug concentrations, way down here on the left, the elimination rate keeps up with the concentration. That's your classic, predictable first-order kinetics. But as the concentration rises and we get closer to saturation, the rate starts to level off. And at really high concentrations, the system is just completely overwhelmed. The elimination rate becomes constant, no matter how much more drug you add. That flat line at the top, that's zero-order kinetics.
So we can actually break that whole curve down into 3 distinct zones, all based on that Km value. At a low dose, when the drug concentration is way lower than Km, we're in the safe, predictable, first-order zone. At an intermediate dose, when the concentration is getting close to that Km value, we hit that unpredictable, mixed-order transition zone. And at a high dose, when the concentration is way bigger than Km, the system is totally maxed out, and we're in that flat, constant, zero-order zone.
Okay, so we've covered the theory and the math, but let's bring this all back to the real world. Why is it so incredibly important to understand the stuff in a hospital or a clinic? Well, it really all boils down to one thing: patient safety. When you're dealing with a drug that follows these unpredictable rules, especially a drug with a narrow therapeutic window where that line between effective and toxic is razor thin, the stakes get incredibly high. Take the anti-seizure drug phenytoin, for example. A clinician might make what seems like a totally reasonable, small increase in the daily dose. But if that patient's system is already close to its saturation point, that tiny adjustment can push them right over the edge. It can cause their plasma concentrations to jump from a therapeutic level into the toxic range. And that is why careful, individualized dosing and really close patient monitoring are absolutely essential with these kinds of drugs. So, let's wrap this up with the key takeaways. First, remember that nonlinearity happens because our body's ADME systems get saturated. They get overwhelmed. This is what creates that dangerous, disproportionate link between the dose and the drug's concentration. The main culprits are maxed out enzymes, transporters, and protein binding sites. We use the Michaelis-Menten equation to describe this big shift from predictable first order to risky zero-order kinetics. And most importantly, mastering this concept isn't just an academic exercise. It is absolutely vital for safely and effectively using drugs that have a narrow therapeutic index. Getting this right can literally be the difference between healing and harm.